All right, let's get to the focus of today's call, which is OHDSI studies. We're going to have 6 different presentations. I've asked each presenter to limit the talks to 6 minutes so we can get through everybody. Obviously, that won't give you a chance to know everything about this, but a good overview. But hopefully you can reach out if you want to collaborate, learn more. We might have time for Q&A at the end. You can also use the chat to ask questions, especially to some of the early presenters. But I also wanted to give you a chance to know how you can learn and kind of keep updated with the regular studies going on in the community, the network studies. So we do have, thanks to Martijn, a OHDSI studies page that you can find right on ohdsi.org. It's part of that top menu. You click on that link and it'll take you to this page, which is a full list of all the ongoing studies in our community. So you'll get a chart like this. It gives you the title, use case, study type, leads, start date, last change, everything like that. If you click on any of the studies themselves, you get more information on that particular study. So here's one on CERVELLO, which we will hear about today. Again, a little more information. And at the bottom, here's a link to the Word doc, some results, everything else you might need. Here's another look. This is Charybdis. We're not going to hear about Charybdis, but you can see all the different results that you can find from the Charybdis study. So please use this page, check it out, see everything that's going on. Maybe you find something that's of interest to you that you want to collaborate on or just follow and learn about. So that OHDSI Studies is right there on the top of ohdsi.org. Okay, let's move right to it. I am going to stop sharing and I will turn it over to Chan for the first of our presentations.
Hello everyone, I'm Chan, and here I'm gonna talk about preliminary results from the study, which is comparative risk of cancer between histamine 2 receptor antagonists. I'm sorry that I'm in the pajamas rather than suit. Please understand me that because it's midnight in Korea now. You may remember before the COVID-19 occurrence in September 2019, there was a very big event in medical society that FDA warned about the probable carcinogen presence of NMDA in the most famous heartburn medication, which is ranitidine or Zantac. Subsequently, ranitidine has been voluntarily recalled from the market. NMDA is classified as a probable human carcinogen based on the results from laboratory tests. And it was also reported that oral intake of ranitidine actually increased urinary excretion of NMDA in human. So if this low dose NMDA in ranitidine increased the cancer risk, we need to recommend vigilant cancer screening for those who used ranitidine, including me and you guys. Similarly, Vasastan, the famous antihypertensive medication, has also been recalled due to presence of NMDA during its production. But the previous reports showed that Valsartan use was not associated with the increased cancer risk in real world, which was published in the BMJ in 2018. So I aim to investigate the cancer risk of ranitidine compared with other H2 blockers. So my study population included those who exposed to one of the H2 blockers of interest longer than 30 days with allowing gaps between the treatment, and I excluded those who used other H2 blockers or those who have the cancer history. The target group was ranitidine user, and the comparator group is other H2 blocker users, including nizatidine, oxatidine, famotidine, and lafutidine. The semetidine users were excluded from the primary comparator group because I found that there is no empirical equipoise between ranitidine and semetidine users in previous feasibility study. The primary outcome is overall cancer except non-melanoma skin cancer, and there is several secondary outcome, including overall cancer, cancer death, and 16 types of cancer. And I employed 119 negative control outcomes. In the feasibility study, I found that there is a notch in the early phase of after the initiation of these drugs. So I implemented 1 year lag period or blanking period. So this is the overall scheme for the primary time and risk. You can see that there is a lag period of 1 year after the drug initiation. So follow-up duration or time and risk starts after this 1 year lag period for intent to treat effect analysis or on-treat effect analysis. Because this study has not been completed yet, here I only show the cohort size outcome incidence. You can see that overall there is a more. I've got the result from the more than 100,000 patients from 3 Korean databases and 2 American databases, and the incidence rate was 17 in ranitidine and 15.5 in other H2 blockers per 1,000 person years. In the negative control outcome analysis showed that there is no low possibility of systematic bias. And I hope you to join the study too. I will close this study soon. You can see every document or the package here, GitHub/Odyssey studies/ranitidine cancer risk. Please join the study. Thanks.
Great, Chan. Thank you very much. If anybody has questions for Chan, I don't know if you, Chan, or you're planning on staying for the rest of the meeting. It is very late there, but if you have questions, please feel free to share them through the chat. Okay, next up, we will have our 2020 Titan Award winner, Jenny Lane.
Hi, everyone. Hopefully you can see my screen okay.
Yes, we can.
Yeah, great. So it's really exciting to be sharing the progress we've made in this study on behalf of my collaborators. I'm Jenny Lane. I'm an orthopaedic surgical resident and PhD student here in Oxford. So it's thought that around 2/3 of breast cancer is hormone receptor positive, and therefore blockade of female hormones that can drive cancer growth is included in treatment for many women. This is used both in the treatment of primary cancer and in preventing recurrence. Tamoxifen was the traditional treatment of choice for estrogen inhibition, but in the early 2000s, aromatase inhibitors were first introduced to prevent the peripheral production of estrogen by preventing androgens converting into estrogens. 2 main forms exist, non-steroidal and steroidal. Large randomized control trials have shown significant improvement in breast cancer survival and time to recurrence with the use of aromatase inhibitors in postmenopausal women. Several of these trials have also investigated musculoskeletal symptoms as secondary outcomes, suggesting an increase in these events for women, particularly carpal tunnel syndrome. There's a biological plausibility for the mechanism by which AIs may cause these symptoms. The role of estrogen has been well documented in osteoarthritis in animal models, and reduced expression of aromatase has been found in tissue taken from patients with hip arthritis. Arthralgia, so joint pain, is commonly reported as a side effect with AI use and has been reported as high as 50%, especially within the first year. Tendinopathies have been reported in the literature to occur in AI use, but these are only in small case series. So this study was therefore planned to ask the question, in postmenopausal women with breast cancer, compared to new users of tamoxifen, is there an association of tendinopathies, osteoarthritis, and carpal tunnel syndrome in new users of aromatase inhibitors? Obviously, according to Odyssey's Principles of Open Science, you can read all about the study in its registered protocol that was placed before we started, and the QR code given here will take you to the GitHub page where you can find all the code and the link to the Schuemie applications that I'll be talking about later. So the study follows a new user design with comparative cohorts, where the target cohort are new users of aromatase inhibitors versus new users of tamoxifen. The patients included must be age 55 or over, have a diagnosis of breast cancer as was generated by the LEGEND study, and be recorded as female in their notes. To replicate the RCT style design, they cannot have used the other drug previously, and they need to have a year of data prior to starting the drug to give sufficient information about their past medical history and their demographics. We've also made some secondary cohorts to compare steroidal and non-steroidal AIs, and to exclude women who take bisphosphonates due to the theoretical potential for confounding in the OA outcome. Our outcomes are broadly osteoarthritis, tendinopathy, and carpal tunnel syndrome. These are made into 26 individual outcomes that include a broad definition of any osteoarthritis or any tendinopathy, and then smaller outcomes for each condition separated by their anatomical site, or if they represent a medical diagnosis or undergoing surgery for the condition. And women are excluded if they had the outcome noted in the year prior to starting the drug. This is a collaborative project between us in Oxford, CIDIAP in Catalonia, Columbia and Stanford in the US, AGU in Korea, and IQVIA and Janssen. And in order to ensure the study could run throughout, we spent quite a lot of time iterating over our cohort diagnostics that you can also have a play with. It's now been run in 18 datasets and across 9 countries, and this has been a really exciting process where we've had 3 iterative rounds, and we've focused on ensuring that the time frame for inclusion marries up to the introduction of AIs into practice, and that it could differentiate appropriately between surgical and medical outcomes, and also to consider which datasets should or should not contribute to analysis depending on what they represent. And this has fed into a final analysis plan that looks like this. In the main analysis, new users are included after the 1st of January 2006, and they are then analysed in an on-treatment or an intention to treat approach. Intention to treat is followed for 1 year or 5 years with a Cox proportional hazards model using a propensity score matched approach. We've got 73 negative control outcomes and a meta-analysis planned if the I-squared is less than 40%. And due to our findings in the US data surrounding the change in surgical coding from ICD-9 to 10, we're also running a sensitivity analysis starting the cohorts in 2015 to determine if a difference in outcome is generated due to the coding change here. And we also plan to work with Mark Suchard's team at UCLA to develop the study to adjust for the competing risk of mortality in datasets where reliable death data is present. Well, everyone likes spoilers, so I thought it'd be rude not to include some. And here are the diagnostics from CPRD, which, at least so far for the UK data, appears to show that our design will meet our criteria in terms of covariate balance after propensity score matching for observed confounding and the systematic error controlling for unobserved confounding. And when we've further analysed and we've further run the final study, the Evidence Explorer link in the GitHub will become live for you to look at too. So I'd like to thank everyone who's collaborated, who continues to make this study great, and also everyone who's helped me learn so much about how PLEs work over the past year, and we'll keep you posted on what happens.
Great, Jenny. Thank you so much for that. That was a really great presentation. Again, I should mention all presenters, if you could share your slides with me after the meeting, I will post them to the community calls page. Okay, I am going to turn it over now to Carmen Olga-Torre for the CERVELLO study. Carmen, go ahead. Carmen, I'm not sure if you're talking, but you're muted.
Yeah. Hello, can you see my screen now?
Yes, we can.
Okay, perfect, thank you. So hello everyone, my name is Carmen, and today I'm going to present you the work we've been doing in the psychiatry work group. This project has been called CERVELLO if you like, and the main objective was to actually characterize the difference in the drug use and the population and everything in the mental health conditions during before and during the pandemic. So the study has mainly 2 objectives. So the first one is to characterize individuals with mental health conditions before the COVID-19 pandemic, and it's mainly a characterization. And the second part of the study was to instead obtain the prevalence of use of psychotherapy drugs in those people with pre-existing mental health conditions before and during the pandemic. So the first challenge for our study was to characterize, to assess which were the cohorts of interest. So we identified 10 cohorts of interest that will represent patients with mental health conditions. Those patients are obviously, those conditions can obviously overlap. So they're not mutually exclusive, and our objective was to actually identify the 10 most common mental health conditions. So what we've done is been designing the study, discussing about the study in a psychiatry work group, and use for the first objective the Cohort Diagnostics tool of the OHDSI, and we shared that in the OHDSI studies repository on GitHub, and this gave the possibility to data partners to actually join the study and to run the package on their own data. All those data have been then collected, and we have finally online shared this Schuemie app where people can actually explore the data and see the differences not only among the 10 cohorts of interest, but also the differences among countries. So at this stage, for the first objective of the study, we have 13 different databases that took part, and we have 7 different countries. So our objective was actually to expand this and try to have as many people as possible, specifically from different parts of the world, to join this network study and to see the differences among not only the cohorts of interest, but also the difference among countries. So the next steps for our study would be to then obtain the prevalence of these psychotherapy drugs in those cohorts of interest among those patients. Particularly, we have focused on 8 types of psychotherapy drugs, and we're going to stratify by year before the pandemic in order to obtain the pattern year by year. And specifically for the pandemic, so we talk about 2020 and potentially 2021 data, we want to see among the stratification made by month, because it might be of the different interest according to the country and the different lockdown, and you can imagine also the different drug pattern. Obviously, we are going to stratify them by age groups. So at this point, we are discussing about the study design within the psychiatry work group. And what we are doing is to create the second part of the study and the second package that is going to be shared within the OHDSI community, and will allow everyone to join the study. So if you're interested into understanding how the COVID pandemic is actually impacting mental health, and how this is impacting especially among different countries, then please join the studies, join the psychiatry work group for more discussion about it. So that's just like my presentation. Thank you. Enjoy the journey.
Thank you, Carmen. Appreciate that. It's obviously an incredibly important topic, mental health always, but certainly right now. A reminder, if you're looking to join the psychiatry working group or any working group, all the upcoming meetings can be found on ohdsi.org. So please check it out and join these working groups, because a lot of the work happens there. All right, let's move now to Aki and the AESI study.
All right, thanks, Craig. Can everyone see my screen?
Yes, we can.
Okay, good. And clearly you can hear me as well, so that's good. So hi everyone, this is Aki from Johns Hopkins Biostatistics. Today I'd like to tell you about a recent OHDSI COVID-19 study I led with Mark Suchard and Danny Pureta Alhambra. So here is a scientific question of interest Here's a clinical question we were interested in. By now, it's widely recognized that many of the severe COVID symptoms are caused by our immune system overreacting to the infection. And somewhere along the chains of biological reactions that leads to this hyperinflammation is alpha-1 adrenergic receptor. So there has been a hypothesis that perhaps by prescribing a drug to block this signaling, we may be able to alleviate the symptoms of COVID-19. So in order to investigate this hypothesis, we decided to identify patients who are using alpha-1 blockers at the onset of COVID pandemics and compare their risks of severe COVID outcomes to those who are taking alternative medications. And since alpha-1 blocker is primarily used to treat patients with benign prostatic hyperplasia, we chose 5-ARI and PDE5 inhibitors as active comparators. And the diagram you see on this slide is the schematic of the prevalent user design we used in our study. And you can't run OHDSI study without a Greek acronym. So I gave this study an acronym AEPIS, who was a king of Argos. As many of you are well aware, defining what constitutes COVID positive diagnosis in this health data is not at all straightforward. But fortunately, in the OHDSI community, we have clinicians and informaticists who knows how to define these things in the right way. So in particular, I was able to take the phenotype definition the Charybdis team came up with and repurpose it for the AEPIS study. And once we decide on the design, the study design and analysis plan, we generate our package and send it around to our data holder friends so that they can run the study in their local environments. And at OHDSI, we like to generate comprehensive evidence. So as is typical of OHDSI studies, we took all the possible combinations of the outcomes of interest, analysis plans, and available databases. So in total, we had 6 databases available to us with enough sample size. One from Spain, Catalonia, CDAP, and the other 5 from US. And our study included 3 million patients, 80% of which were on alpha-1 blocker and the rest on the active comparator. And of course, the OHDSI studies include many state-of-the-art statistical techniques that has been implemented in the HADES packages. So for example, in order to account for the difference in the baseline characteristics between the target and comparator group, we use propensity score method, which groups patients into strata within which their clinical characteristics are balanced. So here, if you look at the differences, standardized differences in baseline characteristics before and after stratification, you see that our propensity score method was able to balance the patient characteristics across the spectrum of baseline characteristics. Here comes the results. Does alpha-1 blocker has possibility to save the lives of COVID patients? Unfortunately, our study indicated no effect. So across 6 different databases, we consistently found that there's no difference in the risks of these severe COVID outcomes between alpha-1 blocker users and the active comparator. So the observational data obviously has some issues, but this is nonetheless a strong evidence suggesting that perhaps we need to be looking elsewhere for potential COVID therapy. So yeah, that's the end of the talk. Thank you very much for your attention. Let's see.
Great, Aki. Thank you very much for that. Also, of course, like all of these studies, very important, very timely. Okay, we will move over now to Xintong Li, who is going to discuss the vaccine AEIS study, the AESI study.
Hi, everyone. Can you see my screen now?
Yes, we can.
Okay, thank you. Cool. So I'm Xintong Li. I'm from University of Oxford, and I'm going to introduce the work which have been done for characterizing the incidence rates of adverse events of special interest for COVID-19 vaccine, and with the team of Professor Danny Brito, Patrick George, and Anna, and also other people within the communities. So the work has been finished and is available on medRxiv, and also the GitHub the link is posted here. So to start it, as we all know, that there are large-scale immunizations programs ongoing across the world. But we also know that those vaccines has been developed in a very rapid speed, comparing with other medications, and they are authorized under emergency use. Also, we've seen these days that there's like news raising on the safety concerns for the vaccines. So this introduced to a concept of the adverse events of special interest in vaccine safety surveillance. The plot I borrowed from WHO, the vaccine safety surveillance manual. So on the top, we see that says all the adverse events, and under that there is a subgroup which is called adverse event of special interest. That is before introduction of the vaccine, and after that, we can also observe the rate of those events among those vaccinated and those unvaccinated. So the background rates we are talking here is the rate of those adverse events happened before introduction of the vaccination. It's an example of how the background rates being used in the current safety evaluation. So this is a screenshot I took from the UK's regulators, that they saying they compare the reported rates of Bell's palsy with the nature rate, which is the background rates we're talking here. So within this, we see that it's important to understanding the background rates of those selected adverse events of special interest for the vaccine safety. And that's why we conducted this study to estimate a set of adverse events in the general population before the vaccine being introduced. So this is a retrospective cohort study. We have included 13 databases from 8 countries, including 5 claims data and 8 HR data. And we estimated the background incidence rates of those selected events from 2017 to 19. And we reported rates stratified by age, Gen 6, and also by databases. And aside from that, we also reported the pooled incidence rates using a random effect meta-analysis model to put all the rates across databases together. Here's the outcomes we included. There's a total of 15 events we included, and this is mostly based on the protocol published by the FDA protocol on the vaccine safety monitoring programs. So we see the events ranging from some more frequency events such as cardiovascular events, and also to some more rare events like transverse myelitis. So here's the results. We include a large number of people and person years in this study. I'm not trying to pronounce this out, but I'm going to say that this a very large study included most people. So first part of the results, this is showing the pooled incidence rates across databases by age and sex group. So the colored represents the classification by the CMOS frequency. So it ranged from very rare event to very common event. So usually people tend to classify one event into a single classification groups. But here, for example, I highlighted the acute myocardial infarction, and we see across the whole row that there are 4 different colors, which tell us that it's not the simple idea. The simple idea of putting one adverse event into one classification is not reasonable. We should definitely take into the age and sex difference into account. And we also presented the database specific incidence rates of the test events. So for for each single plot, all the dots represent a age and sex stratified incidence rates. So we see that for each single age and sex group, there are very big variance or heterogeneities across the databases. And also we can see the incidence trend, the trends with age here. So the solid line and the bar is the confidence interval, and the pooled estimation for the meta-analysis across the databases of each event. And here's another set of the events included. So we see they have different age patterns and also have different magnitude of cross databases heterogeneity. And these are some other events of interest. So to put all the things together, we see that single classification is not enough for sure, and also the use of a single point estimate of the incidence rates to compare with the observed rates in current report is also not reasonable, because we see there's huge age and sex difference of the incidence rates. And also another thing is not negligible is the database difference that even which is beyond age and sex difference. So theoretically, doing a within database comparison might be more reasonable. And also, we hope that the rates being reported in other studies can be interpreted with execution. So yeah, that's all my presentation, and thank you for the community. Enjoy the journey.
Thank you, Xintong. That was excellent. We did have, for anybody who missed it, 2 or 3 weeks ago, a full presentation on OHDSI's work with the FDA BEST program. This a great representative. But if you are interested in more information about the overall work, I would advise you to go back to the community calls page. It was mid-March, maybe March 17th, and watch that presentation because it's really, really informative. Okay, we are going to conclude with Martijn, who is going to go over the EUMAEUS study.
All right, thank you. Let me share my screen. Coming up. All right, can people see my slides?
Yes.
All right, so thanks. I'd like to take the next couple of minutes to talk about the EUMAEUS project. So EUMAEUS stands for Evaluating Use of Methods for Adverse Events Under Surveillance. I'm one of many collaborators on this project, but it didn't make sense to list everybody because the list keeps growing. So a question that a lot of people might have right now is, how do we know whether a vaccine is safe? And well, of course, we all know that all the vaccines that are being used right now undergo randomized trials. And those trials are typically very good for establishing effectiveness, but maybe not so good for when it comes to establishing safety, especially since these trials are quote unquote limited in sample size, often still having tens of thousands of people. But some of these adverse events that people are interested in are actually like 1 in 100,000, and then you might not actually see a single one of them in your large trial. Also, these trials may not be representative of the actual users. There are lots of people being excluded from these trials that would actually benefit from the vaccine later on. Another way to look at vaccine safety is through use of spontaneous reports. So that's something that's been done, is being done quite often. a shortcoming of this approach is that there can be a lot of underreporting, even up to 95% underreporting of adverse events that occur after vaccination. Also, it's not always easy to determine what the denominator is. So you know how many bad things are reported, but you don't know how many people usually were exposed. And also, you need some sort of a background rate, which Xintong's work that she presented just before me actually tries to inform on that question. So a complementary approach that people are considering is to use our observational data. So for example, our insurance claims data or our electronic health records. And then you could, if you like have say a monthly refresh, you could every month evaluate safety of a vaccine. But if we have that data, how do we actually use it to look at the safety? So there are a couple of designs that you could use. One is the historic comparator design, where you can compute the incidence rate somewhere in the past and then see if the rate after vaccination is higher than that historic rate. You could just treat it as a cohort method, where you compare the people that are vaccinated to a sample of people that are not vaccinated and maybe adjust for propensity scores. You can make it fancier with a self-controlled case series design or self-controlled risk interval, where you look at whether the rate of outcomes is higher just after vaccination compared to other time of those same people, or even a case control design where you can ask whether cases are more likely to be recently vaccinated than controls. So several designs are possible, but also once you have a design, there are several ways in which you can declare a signal. One could be what if it's I'm just looking for statistical significance? So maybe p smaller than 0.05 is my rule for calling something a signal. But then what if I do multiple testing? If I look at every month and I do that for say 12 months in a row, I'm actually doing a lot of multiple testing. How do I adjust for that? So another approach that's been proposed and often used for these type of studies is called max SPRT, or maximum sequential probability ratio test. So we have a lot of things to choose from. We can choose different methods and we can choose different decision rules for signaling. And basically, we want to know which method works best. And that's the question that the EUMAEUS experiment is trying to answer. So we designed an evaluation where we look at historical data of vaccines. So for example, the H1N1 vaccines is one of the vaccines that we're looking at. And we have those data, of course, in our databases. We've defined large set of outcomes that we believe are very unlikely to be caused by those vaccines, which are our negative controls. And we also need some positive controls, but in the past we found you can't really use real positive controls, for one reason being that doctors know about them, so they try to mitigate risks. So you can't actually always see them in your data. So we instead use synthetic positive controls. So these are outcomes that are caused by vaccines, but that's because we artificially boosted the rate of the outcome during the time just after vaccination. And with that setup, we can simply ask the question, well, which method is best at flagging positive controls as being signals? But at the same time, of course, you don't want something that just signals everything. So you also want it to not signal the negative controls. So the protocol and the package have been finalized. So we also have a repo in OHDSI studies, and we registered the protocol with NCEP. And well, the results are pouring in, but I did want to just not show you no graphs at all. So a little bit of a spoiler here, but I'm not going to go too much into detail here. This is from one of the databases, the CCE database, for one of the vaccines. And then over time, so everything on the x-axis here is 1 month. As data accumulates for the various methods, you see on the bottom the specificity and on the top the sensitivity. And what you see is for every method, we have some variance, which is denoted by the colors. And so, for example, in this plot for the cohort method, you see that this blue line, the specificity drops pretty quickly. That's because this is the crude one. We're not using any propensity score matching. But that also does mean that you get very high sensitivity. In contrast, the purple one is where we use propensity matching, and we get very good specificity, but that also comes at the price of sensitivity. And so we're now trying to analyze these results. So we're quickly writing all of these papers. The results are coming in, being collected in the database, and can be explored via the Schuemie app. And I'm actually running out of time, so I'm not going to go into all of those. But we have 4 papers that are currently being written and led by several people in the OHDSI community. And with that, I'm at the end of my talk. Any questions? Oh, sorry, that's up to you, Craig.
Well, no, we have about 10 minutes, 9 minutes here. So first of all, I just want to thank everyone. These are excellent presentations and really great work happening throughout the community. And this is not the only studies going on. Certainly, there are a lot more. You can check out the OHDSI studies page. But since we do have these 6 presentations today, I will open the floor. Does anyone have questions for any of the presenters?
Maybe I'll just jump with a leading question for everybody. We talk about the desire to have collaboration, but maybe if everybody could go through it quickly and share what specifically are you looking for from the community in terms of steps moving forward? Are you looking for data partners? Are you looking for someone to help code up some analysis? Are you looking for someone to help with interpreting results? What do you need to help your projects be successful moving forward?
Let's just go in order of how we presented. Chan?
Yeah, I need more data partners for me.
Jenny?
I think I need people who are not inside, because I feel like I've talked about it for quite a long time, because I started thinking about this before COVID. And so I've kind of looked at it for too long, and actually having people with fresh eyes actually really appraise and criticize what I've done before it goes to peer review, I think is probably the thing that I would look for. So hopefully it will all be out there, and I'll make sure that everyone sees it and they can say that.
Carmen?
Yeah, we were, as I said before during the presentation, we are interested in having partners that will contribute, data partners that will contribute with data from different parts of the globe. And then, yeah, obviously, like it would be very helpful to have someone else that will contribute, in the coding part, so we can actually create a better structure, better visualization of the package as well, in order for everyone to actually visualize effectively the results.
Aki?
Yeah, well, AP study is already complete, and I got a lot of help from all the spectrum of OHDSI communities. I've been actually thinking that I need to do more to contribute to the community. I don't have any ask from the community.
Xintong?
Yeah, although we have already got one manuscript out for the study, but I think we do expect more data partners to join as we are continuously evaluating more, like adding more events of interest in with the immunization programs going on. So yeah, please contact us if you're interested in. Yeah, thanks.
And Martijn?
Yeah, so currently we're at the process of writing papers, and we actually could use a lot of help there. So if anybody is interested in contributing, so as I mentioned, we are writing 4 papers simultaneously right now, and each one of those could use co-authors. So yeah, go to our team's page under the POE, and look up all the discussions that are going on there, please, or just reach out to me directly. That's of course also good.
Excellent. Any other questions?
I did see one question from George to me. Should I answer that?
Yeah, go ahead.
So George asked, can we plot the AUC over time to see if discrimination increases as opposed to just sensitivity and specificity separately? So yes, George, we can certainly do that. One challenge I see with AUC overall is that that's not something you can base a decision on. You do need to pick a threshold. So we just having a good AUC is not good enough. We also need a good threshold. So we need to, if we're reporting that out, I think we also need to solve the question, well, which threshold should people use then?
I think there's probably a number of people who maybe not now, but over time, will want to start studies. And that is an entirely new topic for a call that will certainly run. But I was wondering if anybody just had any thoughts they could share about just getting a network study started within the OHDSI community, you know, maybe a challenge you faced and how you overcame it.
I'd be happy to offer a comment. This is Scott Duvall from the VA. From our standpoint, and I'll use Pioneer since that wasn't talked about today as an example. We've done a ton of curation related to prostate cancer data. That's what Pioneer is focused on right now. But we don't have all of that extra curation that we do on our raw data yet in our transformation for into OMOP. And so one of the things that we've been struggling with for many of these studies is just making sure that what's represented in OMOP for all of the very specific concepts there are represented as well as they are in our raw data. Mark's been helping us do this, and so we're coming up with ways that we can kind of look at the raw data and the Cohort Diagnostics, looking at the concepts, how they appear in OMOP, and then how they appear in our raw data to see where we need to make spot changes or just validate that the data we have in OMOP is complete and represents the concepts that they're looking for.
Great, Scott. Thank you for sharing that. A couple minutes left. Any final questions or comments? Okay, great. Well, thank you again to our 6 presenters. If you would please send me your slides so I can get them posted to the community calls page and share over social media. Next week are 10-minute tutorials. Please join for that. We're really looking forward to that. Otherwise, have a great week. Thanks for joining, and we'll see you next Tuesday. Bye, everybody.
Thank you, everyone.